So you've probably been to a patient who has NEAD and you didn't know it. NEAD standing for Non-Epileptic Attack Disorder, also sometimes referred to as a pseudoseizure. The evidence is saying that just by calling someone who's having a NEAD seizure a pseudoseizure, we're actually doing more harm than good. And the evidence is pointing towards the fact that they are in fact having a real event, and we are saying that what they are going through is not real. So we're going to talk about what is NEAD, who gets NEAD, and what we should be doing about it. So NEAD is a type of functional neurological disorder. What is happening with NEAD is that in the brain, there is no firing of electrical activity that we see in a typical epileptic seizure, but we're having a physical event with no neurological electrical activity that looks like an epileptic attack. What that is that the patient has likely had previous trauma when they were young. It is real. It is something that the patient is going through, and by calling it not real or fake or pseudoseizure, we are doing more harm. Who gets NEAD? So typically speaking, the evidence is pointing towards that about 80 to 90% of patients who have NEAD are female. A lot of them have probably been previously diagnosed with epilepsy or on medication for epilepsy. The evidence is also pointing towards the fact that they have more likely than not had childhood trauma. So whether that's physical abuse, emotional abuse, or any other type of abuse. What they need is actually cognitive behavioral therapy, that's CBT. And that within 12 months of that treatment, about 90% will be in remission. So there is actual real evidence that points that this is their management. What they don't need is a bunch of benzodiazepines from paramedics. What they don't need is to go on to epileptic medication. They need cognitive behavioral therapy. So what do we do, and how do we pick up if someone might be having a NEAD seizure? So I've come up with an acronym called SAFE. So this doesn't diagnose NEAD seizures. It just helps us to try and differentiate between a grand mal seizure or a tonic-clonic seizure and a NEAD seizure. So SAFE stands for, the S is for shut eyes. So when someone's having a grand mal seizure, their eyes could be open and their pupils can be pointing in one direction or the other. And typically speaking, someone who's having a NEAD seizure, their eyes will be forcefully shut. You've probably been to this or seen this, and you probably heard someone say, it's just a fake seizure. They're faking it. They're wanting attention. This is a pseudoseizure. And that's exactly what the evidence says does more harm. What they are going through is real. The A stands for asynchronous. What that is that in a grand mal seizure, the arms go together in synchronous, the legs go together in synchronous. And what that means is that the patient is probably having a grand mal seizure, but where someone is having a NEAD seizure, we can have one side of the body going and then the other side of the body going, and it increases and decreases. So it kind of waxes and wanes up and down, and it can increase and decrease in intensity. And that's not what we typically see in a grand mal seizure. The F stands for forever. Typically speaking, a grand mal seizure is about 90 seconds to 2 minutes. They don't just go on forever. And what happens is that with a NEAD seizure, that they can be 5 minutes, 10 minutes with no real airway compromise. And that's what we need to be looking out for. Is the airway actually compromised? So being very aware of the airway and assessing if we have breathing, is this patient oxygenating and having a 5-10 minute seizure? That's when we're going to start to differentiate. And then the E is for express recovery. So typically speaking, someone who has a grand mal seizure will have a period of post-ectal. So we have a period of confusion. And what happens is that the patient will then be very confused and then slowly regain their consciousness or their awareness. With a NEAD seizure, there is an express recovery where all of a sudden they go from having this, what looks like a convulsion, and to suddenly being awake, alert, and knowing what's going on. That is another indicator of a possible NEAD seizure. So what do these patients need us to do? What, as paramedics, should we be more aware of? So what we need to be aware of is that the evidence says is that we tend to over-treat these patients, meaning that we tend to give them too much benzodiazepines to try and stop the seizure. That excess amount of benzos leads to loss of airway. The loss of airway leads to RSI, and the RSI leads to death. The evidence is literally saying that. And so what that means is that we need to be careful about just giving someone benzodiazepines because we think it might be a seizure. We need to be trying to go, hold on, am I being safe? And go through your SAFE to try and work out, is this a grand mal tonic-clonic seizure, or are we dealing with a NEAD seizure? This doesn't mean we now start calling it fake. We don't start calling it a pseudoseizure, and we don't start saying that this patient needs attention. What we need to do is actually document what we see, and we need to try and hand it over to the doctor, because the doctor hands it over to the GP, and the GP then starts to treat this patient. You could probably do a lot of good. So if you can catch them sooner, be better off. Do you think that you've been to a job where the patient had NEAD? Tell me in the comments below.